Trigger finger is also known as stenosing tenosynovitis and is a condition which creates interruption of flow in normal finger bending and straightening. Typically, when an affected finger is bent, the digit initially moves normally and then suddenly snaps into the bent position and becomes locked. This locking in the bent position makes it difficult to straighten the finger, and when it does, it snaps into an extended position, catching over what seems to be an impediment to the movement, which sometimes can be painful. Frequently, locking is so severe that the other hand has to be used to assist straightening, as the finger cannot straighten using muscle exertion alone. So why does this locking or catching occur? To understand this, we need to consider the basic structure of the fingers. The two joints between the bones of the fingers each have a separate tendon assigned to them. The muscle bellies of these two muscles are situated in the forearm. The relative attachment of these two tendons enable us to move these joints independently of each other. The muscle that does this movement is called flexor digitorum profundus, and the muscle producing this movement is called flexor digitorum superficialis. When these joints move together, both muscles are in operation to produce a movement which is known as finger flexion. Unsurprisingly, the tendons of these two muscles in the hand are positioned directly one on top of the other, with superficialis lying above profundus. To protect these tendons from excessive friction causing wear and tear, both tendons are encased within a self-lubricating, friction-free tube called a synovial sheath. In order to keep these tendons running along a true course, they are channeled through the fingers via a series of pulleys. The synovial sheath is also protected by and secured by fibrous bands that also form a tube-like structure. In addition to this, the palm of the human hand is covered by a thick fibrous layer known as the palmar fascia, or the palmar aponeurosis, which forms the characteristic bowl or convex shape of the human palm and also acts as a shield against trauma. Furthermore, the hand and fingers have a protective layer of fat under the skin to further protect and insulate the hand. Despite these protections afforded to the hand and fingers, damage of unspecified cause can occur. This appears to be the case for trigger finger, where for unknown reasons a nodule or swelling develops, usually around the knuckle of the hand on the palm side. While this swelling can resolve spontaneously in around 30% of cases, for the majority it will continue to grow to the point where it becomes a palpable structure in the palm. If the width of the nodule grows to become greater than that of the tunnel or pulley through which it passes, usually the A1 pulley, then symptoms of trigger finger will appear. This is because the presence of a nodule is abnormal. In the absence of a nodule, the finger should be able to move smoothly through its full range of motion. However, the presence of the nodule means that it gets caught in the tunnel, and this gives its characteristic catch during flexion and during extension. Over the years, many treatments have been used to overcome the problems associated with trigger finger. Most of these treatments are inexpensive over-the-counter solutions. The exceptions to these are steroid injection therapy and surgery, both of which are medically administered and relatively expensive. However, in recent years, these inexpensive and some would say ineffective treatments have been abandoned by health systems in favour of cortisone injections as first-line treatment and surgery as second-line treatment. The idea behind the cortisone injection is to shrink the module so that when the finger moves, it's able to pass beneath the A1 pulley without interrupting normal flow of movement. A 90% success rate is frequently claimed for injection therapy for trigger finger. However, this is almost certainly an overestimate. The starting severity of the condition is key to this, with higher severity levels responding less well to steroid injections than low severity cases. Around 20% of people are needle phobic and therefore not suitable for this sort of treatment, and the average success rate reported in the literature using data from randomized trials is around 60%. It should be noted that these randomized trials do not provide follow-up data beyond 4 months, and so the long-term effects of injection therapy are not fully known. Anecdotally, injection therapy for trigger finger has a success rate of about 50%, and it should be remembered that success is not easily or consistently defined. In percutaneous surgery, a surgeon will insert a hooked needle and will slice through the A1 pulley in order to allow a clear passage for the finger nodule to pass through. Clearly, with the absence of the A1 pulley, the movement of the finger is restored. Open surgery requires a small operation using a scalpel incision into the hand in order to divide the A1 pulley. The objective of open surgery is the same as that for the percutaneous procedure and aims to re-establish full range of motion. The academic literature tells us that surgical success rates for trigger finger are between 90 and 97%, with percutaneous surgery being at the lower end of that spectrum and open surgery at the upper end. As such, open surgery is considered the gold standard treatment for trigger finger by providing the most satisfactory solution. However, despite these high success rates, surgery of all kinds has potential complications. While there are some common issues between percutaneous and open surgery, each is associated with specific issues. For example, in percutaneous surgery, surgeons do not have line of sight of the A1 pulley, and the cutting needle must be manipulated by feel, which can result in damage to non-target tissues such as nerves. However, open surgery can result in considerable post-operative soreness, which, for certain manual workers, can mean several weeks off work after surgery, whereas those having percutaneous procedures may not require any time off work at all. The prevailing approach to the treatment of trigger finger might be unappealing for people who do not like the idea or expense of injections or surgery. As such, many people look for alternative treatments for trigger finger. In my book, How to Fix Your Own Trigger Finger, The Journey Begins, I discuss an approach that marries the best of the over-the-counter treatments with more modern self-administered myofascial approaches that release a range of soft tissues implicated in the development of trigger finger. These techniques are explained in my second book, Manual Therapy Trigger Finger Protocol, The Natural Way to Treat Trigger Finger. Those people reluctant to follow the current medically and surgically orientated trends in the management of trigger finger might be interested in looking at these books to see if they assist in providing an alternative way forward for them. And if you'd like to know more about how I treat trigger finger using these new myofascial techniques, click on the thumbnail in this video to see me demonstrate the Mantra Protocol treatment with a real patient with trigger finger. And if you want to know more about how to measure the severity of your trigger finger, you might be interested in my video which deals with this question. Thanks for watching.